Hi everyone, today I'm here with Dr. Kalyan, a local infectious disease specialist. So first of all, thank you for being part of this interview and agreeing to it.
Thank you for inviting me.
It's our honor. So before we get into kind of the details of the specialty, could you just walk us through what infectious diseases and the type of cases you see in a day usually?
Sure. General infectious diseases is broad. So if one chooses to go into the field, they really want to be interested in general internal medicine. So if you're interested in internal medicine or family medicine and you have a keen sense of trying to identify the diagnosis, then I think one would do really well in infectious disease. It really allows you to identify the source of a condition, whether it's infectious or not. Half of the time we look at patients, or we're called on patients, because they have a fever, and that fever may be attributed to an infection or not. And knowing the underlying pathogenesis, the pathophysiology of the problem helps determine whether that fever is related to infection or not. So this is just a small example of what one sees. On a daily basis, we get consults for infections head to toe, really, from meningitis, pharyngitis, to endocarditis, orthopedic infections, post-operative infections, intra-abdominal abscesses. So that's just to name a few. Mm-hmm. So these are what we see on a typical day.
Mm-hmm. So infectious disease is a subspecialty of internal medicine. Are there further subspecialties of infectious disease, or is it just one thing that everyone practices generally?
You can choose to do general infectious diseases, mm-hmm. or choose to practice HIV medicine. You can choose to do infection prevention alone or antimicrobial stewardship. Really, in the community setting, it's probably best to do general infectious diseases just because of the access to the surrounding towns and cities. But in an academic setting, you could probably choose to specialize further into that area of infectious disease that mm-hmm. you might be interested in researching mm-hmm. more on.
Okay, and could you kind of walk us through a typical day in your life from when you come in to when you leave?
After I drop off my kids at school, I come to work, and depending on if I have my clinic day, I do wound care as well. So on days that I come to clinic, I come in, see my patients that I have seen in the hospital as a consult, and I follow them up in the office. So that would be half a day of my office as follow-ups or referrals from the community, and finish off my day as by seeing inpatient consults. And some days I just have pure inpatient consults. It's mostly an inpatient specialty. One can choose to do just outpatient too, but really general infectious diseases is seen in the inpatient setting and then followed up in the outpatient setting. Mm-hmm. So a day could be 8 to 8:30 to possibly 5 to 6:30.
Mm-hmm. And how often are you on call, or do you have to work on the weekends?
So the calls are not emergent calls. So if they're emergent calls, then they end up going to the ICU most of the time. So the mm-hmm. intensivists end up seeing those patients. If they have been seen by us in the office and we get calls in the evenings, I would want to know what happened to my patients. So instead of my colleagues taking those calls, I would take those calls from the office or the emergency room if they end up coming to the emergency room for any questions. But otherwise, weekends mostly, we come into the hospitals. We take calls with our colleagues for 2 or 3 hospitals. We end up seeing consults.
Mm-hmm. Okay. Do you do other things besides your clinical work, or is it mostly clinical focused?
A good 75% of the day is seeing patients, and it's a clinical specialty. The rest of the time, it's antimicrobial stewardship. So I work with the pharmacists a lot, and really surveying antimicrobial use in the hospital and ensuring that patients aren't exposed to unnecessary antimicrobials. Good 40 to 50% of the time, patients get antimicrobials when they don't need them. So reviewing a daily list of patients that the pharmacists initially capture and evaluating whether they absolutely need them or not is the rest of the 25% of the time. So that's antimicrobial stewardship, as well as I do infection prevention, and that has to do with the public health of the community and the hospital. So if a patient comes in with C. difficile or a multi-drug resistant organism in anywhere really, urine or an infected fluid, what to do with those patients from an isolation perspective, from exposure to the hospital staff, and once they get discharged. So that's the infection prevention piece of what I do. And sometimes we have to address local emergencies. So if there's word out there that there's Ebola or Zika or any of these types of viruses, we kind of need to be aware of what's going on so that we prepare our community, our hospital, and the patients that are here. So that's part of it, but that's kind of more of a peripheral evaluation of what we need to do.
Okay, and then how would you recommend physicians get involved in those other like non-clinical things? Do you just ask for it? Do hospitals naturally give you like protected time for other things, or do you have to seek them out yourself by having like special arrangements?
So with more hospitals being looked at from a national perspective on what types of infections occur, there's a greater need for infectious disease physicians looking at the appropriateness of antimicrobial use, the infection prevention piece, as I mentioned, or the emergency preparedness piece. It's part of, you can either choose to do just clinical work, or you can involve yourself in that hospital asking to do work like this. So it really, the need is out there. It's whether one wants to get involved at that level.
So you just talk to the administrator or administration or something, and they'd arrange for that?
Right.
Okay.
The more hospitals are required to have antimicrobial stewardship and infection prevention now. So where the hospitals have that already, some hospitals are really small where they don't have infectious disease doctors there, so they end up having a local doctor handle some of that. Where if someone goes into infectious diseases, then they have the opportunity to run that department, so to speak.
What's the most challenging aspect of ID?
The challenging aspect would be multifold, really. One is the diagnosis. Sometimes the diagnosis is not straightforward. And really we look at the source and we look at the diagnosis. When a patient comes in with a fever of unknown origin, if a patient comes in on a repeated basis for a same organism in their blood, we want to look into it further to determine the source of that infection so we can address definitively how to eliminate that source so they don't come back to the hospital with the same problem. Or if they travel somewhere and they come back with a fever that lasts 2 weeks without a clear source, we want to identify that source and get to the bottom of it really before they have other complications as a result. So that's one part of it, the diagnosis. The next is not so much a challenge, but it's really crucial to communicate with that patient, and sometimes more than the patient, the family. They're worried that they have an infection that they are dealing with, and there might be complications that could occur as a result. So it's really important to communicate that the diagnosis, whether you come to a diagnosis or if you don't. But that communication piece is really important, and sometimes can be challenging because patients look up diagnoses and come in with a preconceived diagnosis, and sometimes we might have to challenge that and kind of retrain their thinking to accept what the possibilities could be, and may not have an answer all the time, and eventually we may get an answer. So sometimes just having that open mind from the family and the patient is helpful to get to the bottom line of why they're here. And the third challenge, I would say, is a buy-in from our fellow physicians and colleagues. Sometimes if a patient comes in repeatedly with a post-operative infection, or they had a device put in, and they keep coming back with a fever where there isn't a clear source anywhere else, and having to convince that other physician that it really is that device that's causing the fever or the infection can be challenging. So it goes back to communication with your colleagues as well as with the patient and families too. So it's a good kind of challenge though.
On the flip side, what's the most rewarding aspect of infectious disease?
I would say several. One, the first and foremost being the gratification of that patient doing better with antimicrobials if it is an infection, or when you find out that it's really not an infection, getting them off of antimicrobials and leading the path to the appropriate diagnosis so that they can get that treatment. So if a patient comes in with a fever and it's not related to infection, you find that the fever is related to multiple myeloma, you're getting them to the right doctor to address that myeloma and not continue antibiotics repeatedly and them not getting better, for example. So that in itself is very gratifying, that you, one, treat them when they really need the treatment, and two, direct them to an alternate etiology if it's not related to infection. And two, when the patients do get better and you see them in the follow-up, it's not just when you see them in the inpatient setting, you see them in the follow-up and you see that progress over time. That's rewarding too. And over time, it's the communication and trust that you build with your colleagues, because they see that you've seen, you're taking care of their patients as well, and so it's not. It's really a collective effort in managing that patient. So that communication is also rewarding. So.
Are there any misconceptions about infectious diseases? Or like the specialty in general?
You have to tell me that. I don't typically hear from your perspective what the misconceptions are, so that I can help correct them. So if I, would suspect that someone might think that infectious disease is a busy day, I would say yes, it's a busy day. It's a specialty that you can choose to do procedures if one wants to or not. It's really a cerebral specialty. One could get involved with something like wound care, where you can do a few procedures and really follow that infectious process if it's an infected wound. What possibly someone might think is infectious disease is a small role, I don't know, but really it's varied. And one can, once you get into infectious disease, it's a whole new world of trying to make a niche for yourself and do what you're interested in. And my interest was in infectious disease, in microbiology, and in diagnosing. So this was just the right field for me. And once I got into it, I was able to identify antimicrobial stewardship interests, infection prevention, and wound care. So I think it's a field that you can really explore.
Since you found a field that really resonated with you, what was your journey into medicine, and what led you to infectious disease in particular?
I wanted to get into a field with that really had to do with multiple aspects of internal medicine. A field such as hem-onc, rheumatology, endocrinology, and infectious diseases, I think probably touch all aspects of internal medicine. What interested me with infectious diseases was I was able to have an impact on that patient immediately once we identified an infection, and had a collaborative effort in getting that patient better. If it happens to be a trauma patient that needed infectious disease to help them out, or an ophthalmologist who finds that the patient has syphilitic uveitis, infectious disease is right there. So it's a specialty that works with multiple specialties, and that really was interesting that I could communicate with other physicians to do that.
How would you recommend us match into a good internal medicine residency and then a good infectious disease fellowship? Any tips for medical students?
I think working closely with infectious disease, first of all, doing an infectious disease rotation in medical school, I think is very helpful. Knowing antimicrobials is important because every specialty that one would go into would touch an antibiotic, right? But whether the antibiotic was absolutely needed is something that only someone who's been exposed to the appropriate use of antibiotics could know, and also know the adverse effects of having used that antibiotic. So I think it's important to at least get some exposure to infectious diseases earlier. Working at an academic center with someone who's doing research in infectious disease would help. I think if you have a passion in a field of infectious disease, whether it be C. difficile or a multi-drug resistant organism, where you can focus on some aspect of infectious disease a little bit more, then that might help get a match into a competitive program.
Okay, and so you mentioned infectious disease is pretty much like an inpatient type of field. So I'm assuming there isn't much like private practice or any private practice solo practitioner type work, or is there locums work, things like that?
Yes. I could do independent work, which I am doing independent work, so to speak. Okay. But I work in a multi-specialty practice, private practice, which includes other infectious disease physicians, critical care physicians, allergists, pulmonologists. So one could choose how they want to practice. As a private practitioner, one could do infectious diseases as well. I chose to go into a multi-specialty group because it is more collaborative. I wouldn't be in a silo of managing patients, and I think going and practicing in a hospital from a perspective of being an independent practitioner has some. I think it's kind of dying off over time, because many physicians are becoming employed by hospitals, and if we can maintain some form of autonomy by working in a private setting still, we can impact that community, patients, independently from how a bigger system would like to run it.
Okay, so you'd say there's still opportunity to do things on your own in infectious disease?
Yes,
okay.
Absolutely.
How well are infectious disease specialists compensated relative to other specialties?
It's probably comparable to rheumatologists, endocrinologists, neurologists. If you're going into infectious diseases to make money, don't get into the field. But I think one can adequately live and do fine and still enjoy life and have a life and enjoy coming to work every day. I don't come into work feeling burnt out. I don't come into work not wanting to come to work. So I think that's that's something to say going into a field where a lot of people, I think, start to retire early because they've had it.
And so what tips would you give us to manage our finances once we become, once we go out in the workforce? Anything to manage our finances well, to make sure we can maximize our income or maximize our financial situation?
I think diversifying what you do is important. So what, in addition to just seeing consults, for example, in the hospital, if you can do wound care, I think that would be good. If you can do hospital work, like antimicrobial stewardship, because these are separate from just consult work that you see in the hospital. So taking a little bit of a few things that infectious disease practitioners can do, I think will help build your finances. That's not to say that you couldn't do others. There are infectious disease doctors who work as hospitalists. So I think you could do a lot depending on how much you want to do. But I think knowing how to balance that is really, time will tell, your circumstances will tell. So I think you can take it however high you want to take it, or do what your. I think it depends on a personal interest and needs.
Okay, and so how would you recommend things that you've done perhaps to prevent burnout and establish a positive work-life balance?
I think it's really important to do other things other than just medicine. So if you have hobbies and passion for something, go after it and not let medicine hold you back. So my interests are music and my children, my husband and family. A lot of outdoor activities with my family, and music. So I think between the two, I keep myself occupied outside of work, which is really helpful, because if it's just work is fine, it's great when you're at work, you need to enjoy it. I think if you don't enjoy outside of work, it'd be hard to enjoy work itself. So you have to separate them in order to enjoy each.
And so for establishing a work-life balance, are there any specific tips that you'd recommend, or is it just trying to keep your work at work and your home life at home?
I know a lot of people want to separate work and life, or family life. Sometimes that's hard to do. To be honest, if you're dedicated to your family, and something needs to be done while you're at work, you've got to take care of it. If you're with your family and something comes up with your patient that needs to be addressed, you've got to take care of it. I think it's hard to completely separate the two. At the same time, you have to be able to say when is too much. If you just keep getting texts and pages from the hospital or from your office about your patients when you're out hiking with your family, you have to say somebody else has got to be able to take that call and be okay with that. And at the same time, if you're at work and you've got a family emergency at school or something that's going on, you've got to be able to have some flexibility to handle that. And so if one can do that and be able to know when is too much in either of those boxes, then I think it'd be easier to have that balance between work and family life. Okay.
How has medicine changed since you started practicing? And are there any trends or things like that you see happening in the future? Any big changes?
Since I started practicing, I've noticed that hospital medicine has really taken over independent practitioners in the field of medicine. So where the generalist or the internist or family practitioner would really handle everything about a patient, now it's really the specialists are managing the individual aspect of the issue of that in that patient, which is great because there's really focused evaluation and hopefully reducing redundancy as a result, but also not so great because some just end up working in their individual silos and not able to connect all the dots and putting that patient as a whole. That can, over time, I've seen if a patient gets a team that's able to put connect all the dots, that's the ideal situation. That's great. But sometimes the patient ends up in various hospital systems, and the specialty care is fragmented, and those dots are not as connected as they should be. So I think there's a plus and minus to this over time that I've seen practicing medicine, and hopefully healthcare can change down the road where we can have the best of both worlds, have the specialty care and someone be able to coordinate the care and have a team kind of an effort for each patient so that healthcare costs can come down, patients can be happier with the care that they get, and appropriate care.
Yeah, it's interesting because I guess previously it was when it was more like generalists. They were able to see everyone, but then they're not as competent in each of the specialties, right?
Sure.
And then now, they often refer patients to a specialist to cover a specific thing, but like you mentioned, that specialist may not be as competent in the other kind of related pathologies that the patient might have.
Absolutely.
But then if you had to get all the specialists together, that would be even more costly, right? So right.
So I don't know what the right answer is, but having a small team of specialists and that generalist to coordinate, really that's the idea of managing care for that patient. If they've got cardiopulmonary issues, kidney issues, an infectious disease issue, that's kind of what we do now. But sometimes the patient gets falls through the cracks, so to speak, because they end up at different hospital systems, or they aren't well connected to the various specialties that they need. And you really need that quarterback to be able to connect with those specialties.
Okay, so I guess hopefully we'll figure out a system in the future that kind of integrates both positive aspects.
Right.
Okay, so if you could go back, would you change your career path, or is there anything you'd change about it?
I don't think so. If I were to do it all over again, I would choose infectious diseases. It really happened to be by serendipity that I ended up in infectious disease. I wanted to do, as I was saying, in a field that really incorporated all aspects of internal medicine. And my chief resident in residency suggested that I do infectious diseases, and I said okay, and found I did the rotation. I enjoyed it immensely, among other rotations as well, and ended up with infectious disease after his recommendation.
It seems like some doctors might sometimes have some doubts about what specialization or things like that, but it's I guess it worked out where you really found what you were passionate about.
Absolutely. I don't think I could do any other specialty, honestly.
That's great.
I think it's great that people can be cardiologists and neurologists and intensivists. I'm happy to do infectious disease.
Okay, so last question. What advice would you give medical students or new doctors on becoming a good doctor?
That's a really loaded question because I think what it takes to be a good doctor, I'm still finding out. I think it's, as I was just telling you a bit ago, I think if you feel that you've understood everything, I don't know if that's enough. I think every day a patient teaches me how to become a better doctor. The same infection can present differently in different patients. So whether it's the infection itself, or if it's the patient's family or the patient, other physicians, I think being open-minded and being open to learning every day possibly might help help someone become a better physician.
Okay, great advice. A very humble answer. So thank you, Dr. Kalyan, for being part of this interview. Thank you guys for watching. If you have any questions, you could leave it down below in the comment section, and I could ask Dr. Kalyan and relay it back to you guys. Also, let me know in the comments who you'd like me to interview next. Thanks again for watching, and have a great rest of your day.